Welcome to the Protecting Your Nest podcast. The O in the ROPE acronym focuses on avoiding organisms that harm us. You may ask, why focus on organisms? Well, because protecting your nest is both about avoiding what harms us as well as adding to our lives what helps us. Ironically, organisms can play both roles since many of us consume organisms in the form of probiotics to improve our microbiome while being careful to protect ourselves from harmful organisms like COVID-19. Who better to ask about organisms than a doc whose life is dedicated to being a little bit of a detective of organisms, a detective looking for organisms that harm us while teaching us how to avoid them when appropriate. Today's guest is Dr. Dr. Treitman, who is an infectious disease specialist in Oakland, Illinois, which is just a suburb just outside of Chicago, Illinois. He's affiliated with Advocate Christ Hospital and is at a role of a chief division of infectious disease doc and a medical director of infection and prevention control. He attended medical school at Tel Aviv University and did his internship and residency at Beth Israel Medical Center in New York, one of my favorite cities, and his fellowship at Northwestern Memorial Hospital here in Chicago, where we both work. So with that, Dr. Treitman, welcome to Protecting Your Nest.
Thank you. Thank you so much, Dr. Hampton, for inviting me. It's really an honor to be able to participate today. So thank you.
I appreciate you coming. I know we're both busy in the middle of our day, and we're recording this during our lunch break. So I really appreciate you carving out some time and just to share some messages of dealing with organisms. And when I created my acronym, I really felt like there are so many root causes of disease, some of which we learn to avoid, like organisms, and some of which we need to add to our lives, like exercise. So I just wanted to make sure my listeners learned a little bit about organisms and infections. And that's why I decided to have one of my partners, one of my system leaders, to come and join us today. So let's start our conversation by telling our listeners a little bit about yourself, especially your journey to becoming an infectious disease doc and why you chose this specialty in the first place.
Oh, thanks. So, yeah, as you mentioned earlier, I'm the chief of ID here at Advocate Christ Medical Center and the medical director for infection control. Both of them for about 2 years. Have been heavily involved with the residency program and medical education over the years. That was really kind of the foundation of why I joined here at Advocate, and a lot of that sort of grew over time. So I think, from a professional standpoint, my journey from an infection standpoint, I think it really started in residency. Medical school also, I think a lot of what we do in life is a lot about what we're exposed to, we look up to, mentors or people that we've been around and we're fond of and wanted to kind of replicate what we saw and what we liked. And so, I had some of that foundation and was exposed to some areas in medicine. So when I started residency, I had a little bit of an idea of what I was interested in. I kind of knew I enjoyed that there's some of the specialties, including endocrinology, I really enjoyed. I really enjoyed infectious diseases. I enjoyed rheumatology. Many of those, are sort of considered more non-procedural, or some people refer to them as the cognitive specialties. And then during my internal medicine residency, which is a 3-year training program, during that we do different rotations, and we see different specialties. And I rotated early on in an infectious disease elective and was really fascinated. Loved the material, found it interesting, really wanted to go home and read that night. And the patients were really interesting. I enjoyed being with the patients, and it just felt right, which was a little bit surprising to me. I don't think I was expecting that to happen, um, and then decided to apply to fellowship, and one step after the next, and here I'm now in this position, many years later.
Awesome. I remember whenever I refer to my infectious disease colleagues, sometimes we refer because we don't know what's going on, right? So, so it's like we kind of hand the baton to you so you can kind of play detective a little bit. So as you've kind of taken your journey in this specialty, how much of your work do you feel is detective work versus, compared to other specialties?
Yeah, I mean, it is. A lot of it is really trying to figure things out. Um, I think every specialty has a component of that. Um, Infectious diseases is such a broad area that because of the breadth that's involved, it's not a very focused specialty. One of the things we say is that we tend to dive into every area of somebody else's specialty. I think almost similar to a general internist or a family medicine doc, that when we're called into a case, we may have a urologist on the case and they're an expert in that area, or there's a lung specialist on the case. And they're more specialized in the lung than we are, but the infection is in the lung. There's times when infections, it commonly, and the reason there's a specialty is because it can involve so many different areas and sometimes multiple. But certainly the detective work, that kind of aspect is a key part of it. It's really I think we think about it as what we refer in medicine, we call it clinical reasoning. And it's really that detailed, trying to get a really good history, trying to nail down and understand really what is the patient telling us, and re-listening. I think we all get so busy in medicine that sometimes it's nice to get a fresh person in there and have them really ask the patient again and kind of go through the history and really trying to pick out the details and see if there's something subtle. And then that kind of helps drive us move forward and helps us determine what tests may need to be ordered until we can get to that final answer.
Yeah, I agree 100% about the listening part. We do have a lot of time constraints. I could imagine when you're rounded in a hospital, you got a certain number of people you have to get to, and you're trying to be a detective, listen to your patients, listen to their families, kind of put the puzzle together. And it can be a challenge, but I also like this idea of it's a team, right? So, the primary care doc has an opinion, the intensivist has an opinion, and everybody can kind of put their heads together. So the value of being in a great country like the US is that you have this team of people who can work together to problem solve, which give you your best chances of kind of walking out of the hospital the way you came. Certainly better than you came in. So I love that. And speaking of critical care docs, I could only imagine. Other than them, you may be a specialty that's really seen the impact of a pandemic, and so I'm curious, when you think about your life, and rather it's, as a physician or even personally, what impact has the pandemic had on you as an expert in the sciences of infectious diseases?
Yeah, I have a feeling this is somewhat similar to everybody outside of medicine, but I think as the pandemic hit, sort of my life, was turned upside down in a way where really it was in February of 2000 and uh, uh, 19. Crazy. Where we really started to focus in the hospital. January there were these reports. I had a friend who was going to China. Um, in I think they were scheduled, or she was gonna go on a school trip, and I remember seeing something in a newspaper, something at the end of December somewhere. I remember forwarding it to her and saying, "Hey, where in China are you guys scheduled to go?" And then in January we started to hear a little bit more reports. And February is really when we started doing planning in the hospital, and then at that point. Um, it became 14-hour days, 16-hour days, until we didn't even know if this was going to come or hit. We've seen these sort of worries come before, and they haven't come and really affected us. And then so once March, the patients started to come in and things quickly escalated. um, And the days were long and stressful, painful to see people coming in and a little bit helpless. That was a pretty significant feeling I remember having. And remember people asking me, what should be our protocols for therapy? What should we do for treatment? And as an ID doctor and being trained in this area, it was all about the data and the evidence and randomized control trials. And here we were with no data, no evidence, and that was really, really challenging. Um, and so it was really all adrenaline, and somehow the first 2 3 months we just sort of pushed and pushed and pushed, and then there was a point where I think it hit us all, I think, in medicine, and then people outside of medicine the same. um, and there was this sort of period where we kind of reflected back on the last few months, and I think began to try and reprioritize. Right, it really wasn't even trying. I think we all felt like we must reprioritize. We must kind of put the priorities on what's important to each of us, individually. I think many of us, look to our families, look to our health, um, and put that as such a priority, and try to continue to do that, as the pandemic went on. And I think we're still seeing it today, in our communities. I think there's been so much impact, uh, I think on all of us individually, and then us as a community, where we've had so much growing and so much change, that it's been challenging, but hopefully we come out, at the end much better than when we started.
Yeah, it's been incredibly. It was really scary for me. I don't have to go into the hospitals anymore, but definitely as a clinical doctor, I remember, as you have suggested, we've all gone through this. Wipe down everything that comes from the grocery store. Uh, there was a time when I would kind of strip down at the door. Didn't want to bring anything home. Certainly, we had an opportunity as clinical doctors to, work from home and do some virtual stuff. But obviously, we have docs like yourself who have to go into the hospital. So I did have that luxury. But when I had to come back to the clinic, it was a little intimidating. And I think that when the vaccines became available, it really changed the landscape, because at least you felt like your body had a little bit more ammunition to protect us. And I'm all about, when I talk about protecting your nest, it's really about really preparing your body for battle in a way. And but that alone did not feel like enough until the vaccine showed up. So I think for me personally, it became a no-brainer that we would have this tool that's so effective. So I really echo some of your sentiments in terms of how you felt. And but again, yes, my priorities have shifted. In fact, this podcast was a birth because of the pandemic. It gave me a little time to think and figure out how I could add value to the world, and that's kind of how it was birthed. But it also allowed me to spend more time with my family in a way I hadn't. So I really appreciated all of that. So another thing that I mentioned a little bit in the intro is this idea of thinking about organisms not only as harming us, but potentially as helping to keep us healthy. Most people are not aware that we're just filled with organisms. So share your thoughts a little bit about how we can view organisms not only from them causing harm, but how they can benefit us.
Yeah, it's a challenge. It's a really fascinating area. It's a challenging area. I think it's an area that's really in its infancy. There's been more and more work done on the microbiome, worth gaining an understanding. But I think at this point our understanding is really in its infancy. Um, I think we kind of need to look at sort of our environment. Our body is sort of living in this environment, and these microorganisms are a part of our environment. Or we have bacteria on our skin, we have bacteria in our nose, in our mouth, in our gut, and this is normal and this is healthy. I think I don't think everyone realizes that, that's normal and okay. Say we wash our hands to remove um, organisms that have the potential to be invasive to make us sick. We're not going to sterilize our hands by washing them. We really can't sterilize our skin, nor do we really want to, for the most part. With some rare exceptions, maybe something like surgery. When there's going to be an incision made. Um, and so, the food that we take in affects our microbiome. And there's I think the little bit that we've learned and understand is that there's clearly a healthy component to this. And so, the type of food that we consume can help this. Um, and then, things that we do, such as taking antibiotics or antifungal medications, can affect that. So when it comes to sort of the microbiome and the concept of infection, I think that's one of the reasons why, as an ID doctor, I'm always really focused on, well, what's going on with the patient. Do they have an infection? Is there something invasive? Is there an organism or bacteria that's invasive, that's actually making them sick? Um, because if that's the case, then an antibiotic is an appropriate choice. We want to get rid of that invasive bacteria, and I want to do it in a way that causes the smallest amount of harm to that microbiome. Um, so the narrowest antibiotic for the shortest amount of time is sort of our optimal goal. And we don't want to give antibiotics when they're not necessary. So I think a lot of this people are becoming much more knowledgeable about. I have patients that rightfully ask me, do I really need an antibiotic? Which is a great question. It's a question I think everyone should be asking their doctor. Um, and my answer is, well, I think so, and this is why. And I try and explain, I think you have, this infection, and this is the evidence I have, and that's why you need this antibiotic. But if my answer was, well, I don't know, you're not feeling so well for the last week. I don't really know what's bothering you, but I'm going to give you this antibiotic and let's see if it helps. There's times when that's okay, but it's usually not. There's some subtle times when we do give what we call clinical trials, but for the most part, we really want to avoid that. Somebody comes in with a cold, that I'm seeing, my patient, and they have children, and their kids both had colds, runny noses and stuffy head and a little bit of a fever. And it went from one kid to the next, then to the
Right.
mom who I'm seeing. It's pretty clear it's a viral infection. And so, we don't really want to be giving antibiotics for viral infections. They're not going to help. And then we're really only introducing the potential risk of the medicine. So it's really always about the risk and the benefit of what we do, and so that healthy component, we want to leave intact.
And what's interesting in my I'm actually studying nutrition and functional medicine with University of Western States, and so you start to dive a little deeper into the value of the microbiome. And some of it is, like you've suggested, there are times when you need antibiotics. And what I've learned to think about beyond the antibiotics is, okay, what happens after you treat? And you definitely kill the bacteria that can be harmful. But the collateral damage is that you may kill some bacteria that's not harmful. And then, so a lot of times in that training, they talk a little bit about, well, how do you replenish the healthy bacteria back? Certainly you do that through your diet, but there may be other interventions that people can think about. And what I like about thinking differently is that you really start to think about not only how do you get your body back to its healthy state, but how do you keep it healthy so that you're less prone to infection. So it's a lot of things to think about. I think in our conventional training, it was really more about let's treat, and then the probiotics kind of came into the scene. But I think that we can go a little deeper. I think we got more to learn about how do we keep people healthy and how do we help them recover from infection if we have to use these interventions. So I think it's really integrating both of them, which is what I try to think about as I think about this process. So another thing that's happened since the pandemic is meetings and meetings and meetings, because there's so much emerging data that we've had to have a lot of meetings now. And I'm sure you recall when we were having meetings, it felt like 3 times a week, 4 times a week, just to talk about COVID because things were evolving so quickly. And so my question to you is, clinicians have to be evidence-based and keep up, but it just feels like during a pandemic, an infectious disease doctor would really have to keep up. So how challenging has it been for you to keep up with all the changes that are occurring, with this pandemic?
Yeah, it's been quite a challenge. As you know from all those early meetings that we had, we were really trying to communicate out the changes that were occurring, the new recommendations, and those recommendations changed, quite frequently. Um, so we keep up really with the medical literature. Um, what changed during the pandemic is normally what would happen is an article would go through the usual peer review process. There would be a 1 or 2 month delay after it was approved. It would finally be published, let's say in a major journal like New England Journal of Medicine. And we would read it maybe that day, maybe that week, maybe a few months later. And then we would talk about it. We had yearly meetings in our different societies, and we got to share the ideas and discuss. And during the pandemic, things were coming fast and furious. The data, the studies were happening all over the world. Certainly with the pandemic starting in China, the Chinese were some of the first to forward studies and data that they had collected. And then when it went to Italy, in other parts of Western Europe. Again, they were doing some rapid research, and then we got hit, and then first in Seattle, and then the rest of the country, and New York and Chicago certainly were soon thereafter, and so the studies were coming fast and furious. And I think one of the big things that changed was the preprint. So a preprint was something I didn't even know about before the pandemic, but these were articles that so the different collaborators in a research project had done their data collection. They had their research completed. They wrote it up. They wrote up their article, and they submitted it to a journal. Um, and at the same time, sort of in concert on these different platforms, they were able to sort of publish in a way this preprint. And so it was before something had been actually peer reviewed. So peer review meaning, I think meaning for the listeners that other experts in the field had gone through the data and that they had felt that the data looked that it had met the criteria from their point of expertise, and then it would get approved. So we were seeing a lot of this material even before that stage. So I think that data was coming fast and furious, and we were learning, but yet we had to be so cautious on what we were reading and what we were learning, um, and and guidelines were changing too from the CDC or other federal bodies. As we learned something, then changes were made, and that's kind of what happens in science: is you learn you did something wrong, and you gotta have to then change based on the new data. So a lot of this was transparent and kind of happening in front of everybody, which I think added to frustration for everybody. So
Yeah, I literally just saw Dr. Fauci comment about the holidays and, are we going to need to, social distance and it's almost like I don't. He felt like he didn't have enough data to answer the question. So it's like you're kind of. It's like the weatherman. You're kind of guessing. You're not sure. You want to give people direction. So, and it's really important that we do the best we can because if you're over guessing, people lose faith and trust, right? So you want to give people the best information, but and man, we are just we're really we should be evidence based as much as possible. But it's tough, and I feel for people like Dr. Fauci, yourself, and any other healthcare leader or scientist who's having to lead the masses and do it with information that's not perfect. So I think that's a challenge, and I definitely understand why that was a challenge for you. So when you think about protecting your nest, it's really about, we're talking today about organisms like COVID-19, and you want to protect your family and your personal nest from infections like that. But COVID-19 sometimes leads to a focus so much on COVID-19 that we forget about the other illnesses that can plague us. So as an infectious disease doc, beyond COVID-19, what keeps you busy at night? What type of other infections are you're continuing to see?
Well, so I'm predominantly hospital focused. We see patients in the office, but I think most of the work we do is in hospitals. So, COVID-19, you know, was has and was and still is sort of, a large part of what we do. But you're right. There's many other, things that are different than COVID-19. And then there's things when you get COVID-19 that you can still get other infections on top of COVID-19. People would come in with COVID-19 and then they get a bloodstream infection. So, in the hospital setting, we see a lot of infections. Things are very in our field. It's very broad, and we see a really large selection of different things. I think some of the common things we see are staph infections. Sometimes they're bloodstream infections or Staph aureus in particular. There's a really kind of invasive bacteria that leads to a lot of significant infections. So that's quite common. C. diff or C. diff colitis, which is a bad type of diarrhea, with antibiotics being a risk factor. So, people come into the hospital and they're sick, they have an infection, and they get antibiotics, and then one of the risks is that they can get something called C. diff. And we're seeing more and more drug resistant bacteria. So, as we give antibiotics, we change the flora, and then the more we do that, people can then develop resistance to antibiotics. So we see a lot of very resistant bacteria to common antibiotics, and so we get consulted to help with those, not infrequently.
Yeah, when you think about how often we see new antibiotics, that could be a little tricky, right? It's like you don't really see a lot of new players, just like pain medicine. You don't see a lot of new players, and it's kind of it makes sense because those things would cost more maybe, and the competition would probably win the day. So you probably won't get the number of people using it. So I think from a profit perspective, that's probably been our biggest. I'll call it the rate limiting step. The thing that keeps us from having innovation is the fact that it may not be profitable to compete against amoxicillin, for example. So I guess that's part of it. And I know that a lot of the conversations these days are around COVID-19 vaccination in the world you live in, the world I live in, but there's obviously some other treatments that are out there to help prevent infection in those who are at risk. So talk a little bit about those treatments, those COVID monoclonal antibodies. And I know that lately they've been even talking about a pill. So I thought it'd be interesting to just bring that up because a lot of people are curious about that and want to know, is that something that makes sense for them or their family?
Yeah. Um, yeah. So I think when you think about COVID, I think the way to, I guess, talk about these different therapies would be the different stages. So, the first is you're not sick with COVID. So what can you do? The best thing that you can do at that point is get a vaccine. That's going to train your immune system to help either prevent or reduce the chance that you get COVID. Once you get COVID, um, so, it's a virus called SARS-CoV-2. The virus starts to replicate in your body. And so that early period of the infection, the virus is increasing in numbers. And so it's really a viral infection in the beginning. What's a little bit different about COVID compared to some of the other viruses is that the symptoms develop somewhat slowly. So there's what's called an incubation period. So people get sick, or they get infected, and they don't know it. So it's kind of day zero. The virus is replicating, and around that third or fourth day, if somebody's going to get symptoms, that's when they start to feel it. They feel something subtle, a little stuffy nose, a little congestion, and then it can progress, and it goes usually typically from an upper respiratory infection, like a head like a regular cold in your nose or your mouth, and then it as it progresses, it can go down into your lungs, and that's when you get a pneumonia. And that usually doesn't happen in the beginning. That usually happens around the sixth or seventh or eighth day. And then your immune system kicks in. So your immune system's trying to do something in the beginning, but it's just not doing much. It's not bringing the virus down. It's not controlling the infection. And then that eighth or ninth or 10th day, the immune system goes into overdrive. And in some people, they get much sicker because their immune system's going into overdrive. So when we think about those therapies, uh, in that early period of time when you still got the viral infection, you want to give medicines that reduce the virus or kill the virus. And so monoclonal antibodies that you pointed out have been one of our tools that have been found to work. And so what these monoclonal antibodies are is they're antibodies that are very specific, that will bind to the viral protein, the spike proteins. There's a little receptor called the receptor binding domain. These monoclonal antibodies bind to one little site. And what they do is they combine two of them. So there's two monoclonal antibodies with a product like Regeneron. And when that happens, the virus can't bind to human cells. It can't bind, therefore, it can't enter the cells, and it can't replicate and produce more of what it wants to do. It wants to produce more virus, just more and more virus. And then the virus gets taken out of circulation, so the viral load comes down. So now the body can finally breathe a little bit. The immune system that's starting to kick in can hopefully get rid of the rest of it. And it's been found to work. And so it works well in people that are still early in that infection period. So the virus still matters, that viral infection period, the third or fourth or fifth day of illness. It's authorized for less than 10 days from symptom onset, but the earlier the better. So if somebody's sick, we want them tested right away. And it seems like it's the most beneficial for people that are at higher risk to get sick. So if you have risk factors for progression like diabetes or obesity or heart disease, or high blood pressure, or older age, over the age of 65, all of those we know increase the risk that you're going to get hospitalized or get really, really sick. And so the monoclonal antibodies, when given early, have been found to reduce your risk of ending up in the hospital, which is a huge impact. So those have been really one of our best tools, but they're really quite challenging to give here in the hospital. In our area. So when you look at our system, looking at Trinity and South Sub and Christ, we're working kind of in partnership, and we have a site in the outpatient pavilion at Christ Hospital within the Advocate South Side system. Um, and in the evening times, that space has been dedicated to patients that need these monoclonal antibodies. But it's tough to give. You have to make sure that we're not exposing other people. We're bringing sick people with COVID into this area, so we have to do it really, really cautiously. You need the nurses to be able to do this. Nurses have been overburdened everywhere else, so to pull more nurses to do this is challenging. Um, and they're either IV or now subcutaneous, so they're not easy to give. It's not just not a pill. So it takes a lot of effort, a lot of moving in concert together to make this happen. Um, but anybody who needs it, we've been able to give it. And so we certainly encourage anyone with risk factors to get tested right away, and then ask your doctor if you qualify. Um, and then you mentioned the pill. So there's been some new data coming out. The most recent data that's come out is a drug called molnupiravir. So it's an antiviral medication. One way to think about it is similar to Tamiflu. So if you get influenza, and you have risk factors, again, risk factors like heart disease or lung disease, Tamiflu has been found to work well, and really the best data is that it makes people reduces their duration of illness. And you got to give it really early. You really want to give it within the first 48 hours. People that end up in the hospital that are really sick, or we will give it beyond that 48 hours because we found other benefits. But you got to give it early because it's a viral infection. So you really want to knock that virus down. So this new pill called molnupiravir in an outpatient trial um, appears to reduce the amount of people that took it. You know, they had a placebo arm, which is like a sugar pill, and then they had the treatment arm, which is the molnupiravir, and there were less people that got hospitalized in the arm in the study that got this new antiviral medication, and also less people that died. So it's very preliminary data. This is, I think, a good example of data during the era of a pandemic. I talked about preprints, but this is data by press release. We don't even have a preprint, a study to actually read and review. What we have is a press release from the company. So it's great news, but we really want to see more data. We're actually involved with the inpatient trial version of this same medication. And so we're doing a trial in the hospital to see if it works in the hospital setting. But again, we don't know, but that study is ongoing.
I think it's exciting because it's for me it's about risk mitigation strategies, and I think the more tools that we have to offer our patients, and the easier it is to get those tools to our patient, I think the better. And I've struggled, with the medicine that's not a pill, because, you just got to, it's the logistics of making it happen. But I think having another option is going to be great. And so I'm just happy that we got a lot of people working 24/7. They're trying to find ways to help patients so that we have less people in the hospital. And of course, people who do get exposed, that they'll have a strategy moving forward. So I'm really excited about that. So I definitely wanted you to kind of chime in that. And you did mention earlier about the importance of being good stewards of our antibiotics, and that's the foundation for reducing antibiotic resistance. And again, we talk a little bit about this in functional medicine. And what I didn't learn in my conventional training is that when you consume antibiotics, particularly when you're young, it could increase your risk for a leaky gut, which then could lead to a lot of chronic illnesses because your body's then going to absorb things that it shouldn't. And that could lead to autoimmune diseases and other factors. And, the research is ongoing. So I tell my patients, as a doctor who focuses on wellness, to protect their nests. In other words, sometimes they should fast. So it's when you eat and what you eat. I reduce a lot of inflammatory foods in their diet. We talk about exercise. We talk about reducing stress. We talk about getting enough sleep and avoiding trauma, healing from trauma. So those are the types of things we talk about. I wanted to, hear from you a little bit about, as you're encouraging families, and you touched on this, to be thoughtful about antibiotics. How do you message that in a way that may resonate with people? Because people want to be fixed, right? And sometimes you have to be a little bit of a salesperson. So, any other additional thoughts on how you approach that?
Yeah, I think the sales pitch has gotten easier over the last few years. I think as we've all been talking about this, it used to be a hard conversation. You're right. So typically, somebody's sick, they come into the doctor, they come in thinking, I need an antibiotic, and that's challenging. That's definitely challenging. Um, I mean, I usually just, I talk to the patient. I talk to them about what I think is going on, and I explain, not only what is going on, but then, why do I think that they don't need an antibiotic? I talk about some of the studies that I'm aware of or some of the data. I think people are hungry for this. Um, and for the most part, you can engage a kind of an honest conversation, and most people, don't want to do harm to themselves. And I think if you have that conversation, that it's that they're much more amenable to not taking an antibiotic after that kind of a conversation.
That's right.
Um, there's always going to be challenges. There's always going to be, disagreement. And sometimes we got to listen to our patients. Sometimes we can miss something and kind of have that honesty and humility that, especially in my line of work, I think, the more we do this, we can be wrong, and I've been wrong, and kind of be humble enough to know, and again, to listen. I kind of mentioned it earlier, is to listen, because sometimes I will change my mind, and there's something I didn't realize or didn't catch, and that will change my mind. So, um,
Yeah, that history again. We said this previously is important because no matter what the data shows, there may be, I don't know, 70-80% of infections may be viral, whatever the number is. But man, that person in front of you, I have a few patients, not many, who they just take longer to respond. So it seems like they need longer courses of antibiotics, so everybody's body is different. I think that you definitely want to listen to people and hear them out while you're kind of doing your sales pitch. So I think I appreciate you being a good listener. And I think all clinicians who hear us talk today will benefit from that approach, because patients sometimes will make you, at least pause and think about your decisions and your recommendations. The other thing I wanted to comment on is just, what I try to do is say, well, if you were my wife, if you were my son, if I had a daughter, if you were my daughter, what would I do for them? And sometimes that'll resonate with people. And I love the fact that you also bring the science to the table. They expect a guy like you to be up to date on the science. And when they hear an expert in your field talk, you would hope that would add a little, influence as well. So everything you're saying makes sense, and I appreciate that. And vaccinations, again, are the strategy that we have really felt is the strategy that maybe protects us the most. But one of the things I learned to do that has served me well. And this happened maybe, as a family doctor, you do a rotation in pediatrics and it's not a good thing, right? So everybody, you stay sick. So I learned at some point early in my career that one of the secrets to not, getting sick is to keep my hands out of my face. So, and that's served me well. Now, thankfully, with a mask, I don't really have to worry about touching my nose because it's covered. But as you think about the recommendations you give people to protect themselves from organisms, other than the vaccination, talk a little bit more about the things that you really want people to focus on.
yeah, I think, first and foremost, one of the most important things to do would be, hand washing. And so, in general, when you're around other people or you're out and about, wash your hands with soap and water. If you can't do that, the alcohol hand gel works very well. The only time the alcohol hand gel probably doesn't work as well is if your hands are really soiled. So if you have, dirt or something on your hands, the hand gel doesn't work as well. But otherwise, the hand gel really, really works well. Um, and the idea of preventing infections, so all the things that you talked about, staying healthy, getting plenty of sleep, trying to exercise, multivitamin. I think all of these things are good and smart general approaches. And then it really comes down to this individual, everyone's got their own individual risks, and everyone's got a different situation, and there's different things that they're doing that could potentially pose risk. So it's trying to kind of narrow down and figure out, what is it that places that person at risk. If somebody it's the summer or fall time, and they live by the forest preserve, and they ride their bike or they walk along a pathway, and there's these beautiful prairies, especially in the south suburbs in Cook County, the forest preserves. Um, it would be to if you're getting bitten by mosquitoes, to use mosquito repellent. There's infections that are transmitted by mosquitoes. There's ticks that hang out on the prairie grass, and when you're walking can jump on you. And so to do tick checks, to wear clothing that is tight fitting on the bottom, so to prevent getting tick bites. So that's kind of how every scenario can be a little bit different. So you try and kind of piece together. I take care of transplant patients for the most part, and so they're immune compromised. So we talk about good hand hygiene. If somebody's sick, I tell my patients if somebody has a cold, a friend or family member, stay away, keep your distance. And this was pre-COVID. So this is kind of stuff everyone knows. It's kind of common sense, but good reminders, good encouragement, it works, and things that are helpful.
Yeah, and I think it's again mitigation strategies, and I think we again it's not like you. Maybe one of the mistakes we made is okay, you got a vaccine, so you can let all your guards down, right? So I think thinking about how much of all the available mitigation strategies we can add to our lives based on our individual situation is vital. I think that that's really critical. And what's funny about walking in the in the forest or on the prairie, some of the greatest creative work has come from that, right? So if you think about artists and people who write songs and things, they get a chance to think. And sometimes hearing the bird chirp or the squirrel walk by is helpful, because we live in such a, busy urban sprawl for some of us. And even the people who live in rural parts, they spend their days in offices and they don't get a chance to connect with nature. So I think that'll help us to protect our nest because we're actually relaxing, letting the body heal. So I think all of that is important. And one of the things I've done, and I wasn't doing this before I started my training and learning about carb restriction and things like that, is I learned the importance of not being vulnerable to infection and ensuring that my immune system and my patient's immune systems and my family's immune system is in the best position to fight against organisms that they're exposed to. And I learned some of that in my functional medicine training. Again, I learned it in my low carb space, and I also learned that oxidative stress. And I always give the example of the apple that you cut open and it turns brown. And we don't want that to happen to our arteries and, things like that. So oxidative stress and having some understanding of that is really important because I learned recently that in African Americans, they're more prone to oxidative stress as well. So that they're more likely to, succumb to the overactive immune system whenever they're exposed. So there's no perfect test for oxidative stress. In my practice, I check bilirubin levels, uric acid levels, GGT levels, and they're helpful because they give me a sense of a patient in front of me is if they're at risk for that, and I use it to help remind them that if we make some lifestyle changes, if we protect our nests, we may be able to make those numbers more favorable. So, and because there's so many chronic illnesses you mentioned earlier, diabetes, hypertension, obesity, these are things that make us vulnerable, particularly as we think about COVID. So I'm thinking about the work you're doing, and obviously a lot of people are at risk because they come in with a lot of chronic medical conditions. And I just want you to speak a little bit about what you've seen in terms of that correlation. You did mention some of those conditions already, but I mean, is it really something that's obvious when a person comes in and they don't do well? They tend to have those chronic medical conditions, which also would suggest they have oxidative stress. What would you say about that?
Well, so I think there's a lot of truth to that. I think the data clearly supports that. The scientific data as a whole, that's what we know is the truth. On an individual case by case basis, certainly somebody who comes in who's obese, who has very poorly controlled diabetes, who's elderly, and has high blood pressure that's uncontrolled, you know, that's not a very good sign. If they have COVID and they come in with those risk factors, that's not a good sign. Um, but there's situations that that just sort of surprise you. That maybe that person with four risk factors, yeah, they didn't do great. They got hospitalized. They spent a week in the hospital, but they went home and they survived, and hopefully that they won't have too many sequelae. Um, and then you'll have a strange case where you'll have a 20-year-old without health problems that are known, who does very poorly. So there is kind of this sort of unknown. We don't understand everything. I think as a whole, when you talk about the percentages and the relative risks and the percentages, absolutely those things play out. But on a case by case, we've all been so surprised at the young person who we thought was going to do great, who just does horribly, and it's just it's always so painful to watch. Again, because these are preventable now. This is a vaccine preventable illness. So not only can we work to control you know your high blood pressure, to see your doctor and get that better controlled, work on your diabetes, try and lose weight if you're overweight, exercise, all these things to make you healthier, to reduce those risk factors. But then the vaccine, being so important to all of that, and to help support your immune system.
Yeah. And I again, controlling your controllables is what I'm also hearing, because you don't know. You may be that. I did have somebody in their 30s who succumbed to the virus, and they didn't have a long list of medical problems. Most of the people did, but it's something that really stands out. So I try not to worry about what I can't control. I really think we all could benefit from that approach. And then whatever we can control, we'll use our risk mitigation strategies for that. And then you got to let the chips fall where they may. And I think that's a safer approach, because when you spend a lot of time thinking about stuff you can't control, you're pretty much wasting your time because there's not much you're going to get out of that. So I think that's really important. I know sometimes, speaking of that topic, people have been exposed, rather they were, having a lot of symptoms or not, rather they were hospitalized or not. And then, the question is, and there's supplements out there, that people may use that, gives their body a chance to maybe recover. You hear about that. So I just want you to just share, are there other recommendations that you make as a general rule? Make sure you're taking this vitamin, make sure you're doing that, just to kind of give their body a chance to fight the infection or to recover faster.
Yeah, I don't usually recommend a specific vitamin. Um, I think trying to eat a well balanced, healthy diet is really important as a prevention method. But that's not easy to do. We're all really busy. A lot of people are working hard, and that's not always the easiest thing. That's why I think a multivitamin is a reasonable approach. Certainly, if somebody has a vitamin deficiency that's been identified, that's different, and that deficiency needs to be replenished. There's been a lot of work and a lot of trials done to try and see, is vitamin D deficiency or some specific vitamins risk factors for progression of severe COVID. And the data has been pretty inconclusive. And a little bit of data, especially vitamin D, was one that was maybe suggestive early on. Once somebody has COVID, it hasn't been shown that the vitamin D replenishment at that point is of much benefit. But it's really an area that is it's somewhat unknown. It's really not clear. I do think there are other trials. I'm aware of a trial that's going to take place from a physician in our community to try and look at the potential benefit of some of these vitamins. Um, so I usually approach it, more from a general standpoint, from a multivitamin. Many of my colleagues in the hospital will prescribe some of these vitamins, vitamin C, zinc, vitamin D, while the patients are hospitalized. And I don't think there's a whole lot of downside to doing it in that setting. There are some vitamins that could potentially be harmful if you take them outside of the hospital and if you don't really know what you're doing. So I certainly would encourage somebody to talk to their doctor and be careful that even if something is natural, doesn't mean it's safe.
And I'll just add that the diet will always have more impact than the supplements. Like, so it's like we get into this mindset that, man, if I just took that and then we're gonna go to the fast food restaurant, that's gonna be okay. And we already know that's not the right answer. So I think, and that's one of the great side effects of COVID is that we are cooking at home. So we tend to eat more real food because we're doing that. Hopefully, it's not the noodles that's made of flour, but actual real food like cauliflower. But I tell you, it's really important that people understand the supplements have no significance compared to real food. And I think that's a great, safe way to go. And for those clinicians who suggest supplements, that's fine. But man, don't forget to suggest the nutrition, the food to come with that. So as we, get towards the end here, I know you're busy, and I know that there are challenges in being in the hospital and the clinic, and so um, so talk a little bit about work-life balance. I know that's a challenge under the circumstances, and but what have you tried to do to have a little balance in your life so you can actually continue to do the work you're doing?
Yeah, it's a tough question. I think the pandemic has certainly brought that to the forefront, but I think one of the things I've tried to do is to say no more. In a work situation, no is not something I've been comfortable with over the years. When you have somebody ask you to do something, I think the reflexive answer has always been yes, and then you figure it out later. So I try to prioritize a little bit more. I've tried to get very well capable colleagues to maybe help in areas that I don't have the time to get to. So I think from a work standpoint, trying to really offload things that I don't have to do everything, and there's a lot of really smart people out there that can do this stuff just as well as I can, and trying to get them to help. The life part, I've really made a bigger effort on trying to eat healthier. Really tried to be much more focused on that. Trying to exercise. I find if I don't do it in the morning, I won't do it. I think everyone kind of knows themselves. I used to try and save it for the evenings, and that was doomed to fail for me personally. So I try and prioritize that for the morning. I'm not perfect, but I try. I'm more willing to miss a meeting in the morning. I never would do that in the past. Now, I have an 8 a.m. meeting. It's not a must for me to be at, and I won't miss my exercise because of that meeting. And certainly in the past, I would not have exercised. I would have attended that meeting. And Trying to get outside, spending time with family. I think during the pandemic, we've all realized sort of what's important to us, and it's and family, and and close friends are. I think for many of us, the most important, and to me too. Getting outside and going for a nice walk with your family, and it's been sort of a key for me, I think, to kind of keep perspective.
That's right. Well, it's funny. Again, you're an expert in infectious disease, and I always tell people keep it simple, right? So a lot of times they'll, pay a big copay to go see a specialist like yourself, and you're like, get some sleep, take a walk. It's like, it's like, it's funny because it's really mastering those things first, right? And I think that if people could really do the obvious stuff first, then the things that they really worry about probably won't happen. So I like those answers. And you kind of answered my last question, which I ask all my guests, which is, how are you going to protect your nest? And, you kind of touched on nutrition. You touched on exercise. The nest is also stress and, reducing that and increasing sleep. And if we've had trauma, we repair ourselves from the trauma. If we're not thinking in a way that serves us, we fix our thinking. And then the rope, because we got to climb up to the nest because we're humans, and the relationships. I just wrote an article in a Diet Doctor about relationships, and there's a link to a book called Boundaries. And for those who can't say no, it's a great book that teaches us how to say no. So we won't be enablers and saying yes to people we shouldn't. Today, we talked about avoiding organisms that harm us. And the P is avoiding pollutants. And as you know, on the south side of Chicago, a lot of pollutants potentially from the factories. And then the E is for protecting our emotions and making sure our life experiences serve us. Like my life experience, getting to know you better, is being served. So I appreciate you being here. So any other parts of that nest and rope that resonate with you, or did we kind of cover it with the things we've shared so far?
Yeah, I think we've covered it really
Yeah.
nicely. Thank you so much for the conversation, the opportunity to join you today. It was fun. I really
Yeah, it's
appreciate
good. I know we bump heads in meetings. We have similar bosses that we report to,
it.
and just being able to have a conversation with someone I respect has been wonderful. And I really want to thank you for that. And I know we're going to get back to work in a moment. And I'll just say a few thoughts, and we'll do just that. So thanks again. Okay.
Thank you.
All right. So, guys, for those who are listening, it was nice to hear from an expert in infectious diseases, because if we're going to protect ourselves, we need to understand that organisms can harm us. So rather you avoid those organisms by keeping your distance from them, keeping your hands off your face, as I discussed earlier, covering your face, taking vaccines, or even just making sure you do things to reduce oxidative stress. I hope this episode and the others you've heard are helping you understand that protecting your nest requires a focus on many factors that are the root causes of illness. So I really want to thank all of you for just carving out a little of your valuable time to be with us today. And as we wrap up, I only ask that you be safe, be well, and continue to protect your nest.